Welcome to Uniquely Spoken Podcast, empowering healthcare, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. Welcome back to Empowering Healthcare, where transparency sparks transformation. I'm glad you're here for episode 21, Communication Breakdown, the hidden safety risk nobody budgets for. It's 6:47 p.m. on a Tuesday. Shift change at Willowbrook's Care Center. Martha Ellison is 84 years old. She's lived on the second floor for 11 months, and everyone knows her. She likes her coffee black, she naps after lunch, and she always asks the aides about their kids by name. She's also, as of this morning, on a new blood thinner. Her physician ordered it after a cardiology consult, and the order came through around 10 a.m. that morning. So here is what happened next. 2 days later, we know that the physician's order for the anticoagulant, also known as a blood thinner, was faxed directly to the pharmacy, where it was entered into the facility's electronic health record. The order itself was accurate and available in the record, and the medication had been administered for 2 days. The challenge wasn't a transcription error or a missed dose. It was ensuring that the clinical significance of the new medication, combined with Martha's poor intake and developing a bruise, was communicated and recognized across all caregivers. The certified nursing assistant who bathed Martha that afternoon noticed a small bruise forming on her forearm. Nothing dramatic, the kind of mark an aide sees a dozen times a day on frail skin. She mentioned it in passing to the nurse heading out the door for a 15-minute break. The nurse nodded, intending to note it after her break. Then a call light went off, then another. Then a physician called back about a different resident. The bruise never made it into documentation. The nurse intended to include the information during shift report, but the end of the shift handoff was rushed and fragmented by multiple interruptions. The information existed in separate places: the pharmacy record, the aide's memory, the nurse's mental to-do list, but the full picture never came together during report. At shift change, the outgoing nurse gave verbal report to the incoming nurse. It was a busy handoff. 8 residents in about 6 minutes standing in the hallway, interrupted twice by the phone at the nurse's station. The new blood thinner was mentioned, but only as cardiology added something is in the record. No one mentioned the bruise. No one mentioned that Martha has also skipped most of her dinner, which might have been relevant because a new anticoagulant paired with a resident who's barely eating and possibly dehydrated is exactly the kind of small pattern put together tells a bigger story. By 10 p.m., Martha had a bruise on her arm that had grown larger. And by 2 in the morning, She was unsteady, walking to the bathroom, and fell, striking her head. She was sent to the hospital. She survived. She recovered. Eventually, though, the fall cost her weeks of mobility and confidence she never fully got back. When the facility conducted its root cause analysis, nobody had done anything wrong in isolation. The physician gave a correct order. The pharmacy entered it correctly. The aide reported the bruise. The nurse intended to relay it all. Every single person did their job. And still the information that mattered most, new blood thinner, developing bruise, poor oral intake, increased fall risk, never assembled itself into a single picture in the mind of the one person who needed to see it whole. That is what a communication breakdown looks like in long-term care. It rarely looks like negligence. It looks like a dozen conscientious people, each holding one piece of a puzzle, none of them realizing the other pieces exist. There is a communication myth. We talk constantly, so why are we missing information? If we walk onto any long-term care unit during any day shift, you will hear constant talking. Nurses talking to aides, aides talking to each other, someone on the phone talking to a physician or a family member or pharmacist, a family member asking a question at the desk, or while the nurse or medication aide is passing medications. You hear overhead announcements, call lights beeping. It is, by volume, one of the most communication-saturated environments in healthcare. And that's exactly what makes this problem so counterintuitive and so dangerous. We assume that because people are talking all day, information is moving reliably from person to person. But talking and communicating are not the same thing. Communication, in a safety sense, means that the right information reaches the right person at the right time, in a form that they can actually use and act on. Talking is just noise until it meets that criteria. Some of the most critical information in long-term care is still carried almost entirely by conversation, person to person, out loud, in hallways, at bedsides, over the phone, in the 30 seconds before someone rushes off to answer a call light or perform another task. Structured tools and documentation systems, they exist, but a significant share of what actually keeps residents safe still depends on someone remembering to say it or document it to ensure a clear report is conducted, and someone else remembering to have heard it. That verbal layer of communication is not a flaw by design. In many ways, it's what makes long-term care communities feel human. The aide who mentions to the nurse or medication aide that a resident just doesn't seem like herself today is offering something no checkbox can capture. The problem isn't that verbal communication exists. The problem is when verbal communication is the only communication. When a nurse or medication aide fails to have time to document and ensure they are reporting based on what has been documented. When the informal channel is carrying information with formal, safety-critical weight and there's no backup system to catch it if that channel gets interrupted. Think about what has to go right for a piece of verbal information to travel safely. The person who has the information has to recognize that it matters. They have to find the right moment to document and to share it. The person receiving it has to actually hear it or remember to go back and read it. Not just be in the room when it's said, but process it, retain it, and remember to act on it. Often while several other things are competing for their attention. And then that second person often has to become the one who passes it on to a third person and a fourth. Each handoff another chance for the message to get diluted, forgotten, or lost entirely, especially if the documentation is never completed. This is sometimes called the telephone game. Problem, and it is not a cute analogy. It's a real and well-documented phenomenon in patient safety research. Every additional person a piece of information passes through increases the odds that some detail changes, some nuance is dropped, or the message doesn't get passed at all. With leaner staffing and a heavier reliance on verbal culture, long-term care has fewer redundant pathways for information to travel and fewer safety nets to catch what slips through. One missed conversation can mean the information simply doesn't exist anywhere else, especially, again, if it is not documented for someone to eventually capture the missed communication. There's also a subtler myth we should name directly. The belief that if it's important, someone will say something. That belief assumes ideal conditions, a calm, unhurried moment, an attentive listener, no competing urgencies. Long-term care almost never offers those conditions. It offers hallway handoffs squeezed between two other duties or more. A nurse or a medication aide who is already thinking about the next resident. A message delivered once, quickly, with no repetition and no verification that it landed. None of this is anyone's personal failing. It's the predictable result of relying on an informal system to do a formal system's job. And that gap between how much weight we put on verbal communication and how much structural support we give it is where communication breakdowns are born, particularly if a nurse or medication aide is overwhelmed with medication management and high staffing to resident ratios. And now let's talk about the nurse and medication aide as communication hubs and why that can't be a solo job. If there is one role across nursing homes, skilled nursing facilities, and assisted living communities that absorbs the full weight of this communication gap, it's the nurse and medication aide. Not because nurses and medication aides were formally designated as the communication hub of the building or unit, but because in the absence of a better system, that's what the job has quietly become. Think about what actually flows through a nurse or medication aide during a single shift. Physician calls with orders and updates. Family members call with questions, concerns, and requests. Therapy requesting PRN pain medications or communications related to the resident. Aides reporting changes in conditions, behavior, appetite, mood, skin integrity, mobility. Pharmacy calls about medication availability or interactions. Administrators need information for incident reports or family meetings. hospital discharge planners called to coordinate a resident's return or admission. And all of this is happening while the nurse or medication aide is also physically administering medications, performing treatments, documenting care, and responding to whatever emergency arises in that moment. This is in many ways similar to air traffic control. An air traffic controller manages multiple incoming and outgoing signals simultaneously, has to prioritize correctly under pressure, and cannot afford to lose track of even one plane in the pattern. Nurses and medication aides in long-term care often find themselves managing a comparable volume of incoming information under similar pressure. But nurses and medication aides remain the central clinical communication hub, not because they were formally designated as an air traffic controller, but because effective information flow ultimately depends on support from ward clerks, pharmacy staff, therapy teams, physicians, and nursing assistants. Communication reliability improves when responsibilities are distributed intentionally rather than concentrated in a single role. We've talked about in earlier episodes about what happens when a ward clerk position disappears. Historically, ward clerks served an important operational role. They managed incoming calls, coordinated physician communications, tracked pending requests, monitored fax traffic, contacted pharmacies regarding medication availability, and helped organize information flow on the units. They did not replace clinical communication between nurses, but they reduced interruptions by serving as a communication buffer. When that role disappears or is stretched too thin across other duties, the messages don't stop coming. They just stop being caught by anyone before they land directly on the nurse or medication aide, mid-medication pass, mid-treatment, mid-everything. You see, Mary Ellison's story is a good example of this. The clinical information itself, the order, the bruise, the missed meal, existed accurately in different places and different minds. What was missing wasn't a single fail-safe person to catch it. It was a system that reliably brought those separate pieces together before the next shift began. The result is when communication support roles are reduced or absent, nurses are left to serve as the central node of an information network without the tools, staffing, or protected time that any real communication hub would require. And because nurses and medication aides are conscientious professionals who care about their residents, they don't refuse this role. They absorb it. They carry it in their heads, on scraps of paper, in mental to-do lists that grow throughout their shift. And human working memory, no matter how skilled or experienced the nurse or medication is, has limits. It was never designed to serve as an electronic health record. This is worth saying plainly because it reframes the entire conversation. When a critical piece of information gets lost, the honest question isn't, why didn't the nurse or medication aide remember that? The honest question is, why did our system require one person's memory to be the only place that information lived? or the time to document it and communicate it from their memory to the electronic health record to ensure it is communicated to the incoming nurse or medication aid. Let's talk about interruptions, multitasking, and cognitive overload. Interruptions, because they are the mechanism through which so much of this breakdown actually happens. There's a well-known concept in patient safety research, sometimes called the interruption cascade. The phenomenon where a single interruption doesn't just delay a task, it fragments it. A nurse or medication aide preparing medications get interrupted by a phone call, a family member, etc. They have to mentally bookmark exactly where they were. With medication, with resident, which step in the process. Set that aside, handle the new task, and then return and reconstruct their place. Do that 3 or 4 times during a single medication pass, which is realistic in many settings. And you've already created multiple opportunities for a step to be skipped, a detail to be missed, or a piece of incoming information to simply evaporate because there was no capacity left to register it. Medication administration is widely recognized as one of the highest risk moments for exactly this reason. It requires sustained attention across multiple checks. Right resident, right medication, right dose, right route, right time. And it is also by the nature of nursing unit layout, one of the most interruption-prone tasks in the building. A family member stops a nurse or medication aide in the hallway. A call light goes off 2 doors down. A member of the clinical team needs a quick answer about a resident concern. None of these interruptions are unreasonable on their own. Collectively, they create an environment where critical communications, Mrs. Ellison seemed unsteady this morning, competes for the same limited attention as which pill goes to which resident and something has to give. Documentation carries the same burden. Nurses and medication aides are often documenting late in the shift, compressing hours of observations into rushed entries, trying to recall details that may have been blurred together after a 12-hour day. This is not a discipline problem. It's a design problem. When documentation happens in real time, immediately after an observation, the information is accurate and complete. When it happens hours later, squeezed in around competing demands, some of what mattered most has already faded. There's also a quieter form of cognitive overload worth naming. The sheer number of separate communication channels a nurse or medication aide has to monitor. A phone ringing, a call light system, a text or messaging app some facilities use for quick updates, family members physically approaching the desk, physicians calling in orders, pharmacies calling for clarifications or questions about medications. Each channel has its own rhythm and its own urgency, and none of them are unified into a single prioritized stream. The nurse or medication aide has to mentally triage across all of these simultaneously, deciding in real time which incoming signal deserves attention right now and which can wait. And that triage itself takes cognitive energy that isn't available for anyone else. None of this means nurses or medication aides need to simply focus harder or multitask better. Multitasking, in the way we often use the word, is largely a myth of human cognition. What actually happens is rapid task switching, and every switch has a cost. The fix isn't asking the human brain to overcome its own architecture. The fix is redesigning the environment so that fewer safety critical messages depend on surviving that architecture intact. It's worth pausing here to acknowledge something leadership teams don't always want to hear. Adding more policies on top of an already overloaded communication system can make things worse, not better. If every new safety concern generates another form to fill out, another box to check, another verbal reminder to remember, we haven't reduced cognitive load. We've added to it. The goal of good communication design isn't more communication. It's more reliable communication, concentrated in the moments and channels that matter most, with the noise stripped away. A single well-designed handoff tool that takes 2 minutes to complete accurately is more than 5 separate optional systems that each capture partial, inconsistent information. Simplicity used deliberately is itself a safety intervention. Communication systems also suffer when leadership changes repeatedly. Every administrator, director of nursing, resident care coordinator, resident care director, or department leader bring new expectations, revised processes, and different interpretations of policy. Frontline staff may find themselves trying to follow multiple versions of the same process, creating uncertainty about who communicates what, when, and how. Even good policies lose effectiveness when staff no longer have a consistent understanding of them. You see, there is a hidden cost of communication failure. Here is something that almost never appears on a financial report, a quality dashboard, or a board presentation. A line item called cost of communication failure. And yet it may be one of the most expensive categories in the entire operation. Consider what actually flows downstream from a missed handoff detail or an undocumented verbal report, a medication error that requires a physician notification, additional monitoring, sometimes a hospital transfer, a fall like Martha's that leads to an emergency room visit, imaging, a hospital stay, and weeks of rehabilitation that may never fully restore prior function. A delayed treatment because nobody realized a wound had worsened until it was flagged on the next shift, or the one after that. A family who arrives for a visit and discovers their loved one was sent to the hospital without anyone calling them first, not from malice, but because the number was in one chart and the event happened on a shift where the person who normally made those calls wasn't the one who received the information. Each of these has a visible cost, a hospital bill, a survey citation, a liability exposure, a bad review. But there's a second layer of cost that almost never gets counted because it doesn't show up on a single event. It shows up as erosion. Every time a family member is blindsided by news they should have received sooner, trust in the facility erodes a little. Every time a nurse or medication aide discovers hours into a shift that they were missing a piece of information they needed from the start, their confidence in the system erodes a little. Every time a CNA reports something important and later learns it never reached anyone, their willingness to keep reporting things, even small things, erodes a little too. That's perhaps the most dangerous cost of all. When frontline staff quietly learn that raising a concern doesn't reliably lead anywhere, they start raising fewer concerns. Not because they stop noticing things, because the system has taught them transaction by transaction that noticing isn't enough. There's also a workforce retention cost hiding inside of all of this, which connects directly to conversations we've had in earlier episodes about burnout and turnover. Few things exhaust a caregiver faster than carrying the anxiety of, did I miss something? Did that message actually get through? On top of already demanding physical and emotional workload. Staff who feel like they are constantly at risk of being blamed for a systemic failure, even when leadership doesn't intend blame, tend not to stay long. They do not feel safe. And every departure costs the organization in recruitment, onboarding, and the loss of the very continuity that good communication depends on in the first place. Compounding these challenges are uncertainties surrounding regulatory and reimbursement changes, which can create additional anxiety for providers already struggling with staffing, turnover, and communication infrastructure. None of these costs show up neatly on a P&L statement labeled communication. They show up scattered in incident reports, in survey findings, in turnover data, in family complaints, in liability claims, disguised as separate problems when they may share a common root. That's precisely why communication infrastructure so often loses out in budget conversations. It's difficult to point to a single line item and say, this is what poor communication cost us this year, even though added together across every downstream consequence, it may be one of the largest costs the organization carries. Simplicity used deliberately is itself a safety intervention. There's also a quieter form of cognitive overload worth naming. The sheer number of separate communication channels a nurse or medication aide has to monitor. A phone ringing, a call light system, a text or messaging app some facilities use for quick updates, family members physically approaching the desk, physicians calling in orders, pharmacies calling for clarifications or questions about medications. Each channel has its own rhythm and its own urgency, and none of them are unified into a single prioritized stream. The nurse or medication aide has to mentally triage across all of these simultaneously, deciding in real time which incoming signal deserves attention right now and which can wait. And that triage itself takes cognitive energy that isn't available for anyone else. None of this means nurses or medication aides need to simply focus harder or multitask better. Multitasking, in the way we often use the word, is largely a myth of human cognition. What actually happens is rapid task switching, and every switch has a cost. The fix isn't asking the human brain to overcome its own architecture. The fix is redesigning the environment so that fewer safety critical messages depend on surviving that architecture intact. It's important that we talk about building communication systems that protect residents and staff. So, what does it actually look like to treat communication as a safety system rather than a soft skill or an administrative afterthought? The good news is that this doesn't require reinventing long-term care operations. It requires being deliberate about closing the specific gaps we just walked through. Start with handoffs, because that is where so many breakdowns concentrate. A structured handoff tool, something as simple as a standardized format covering diagnosis changes, new orders, pending labs or appointments, skin or behavioral changes, and family communication needs, gives verbal report a backbone. It doesn't replace conversation between nurses. It ensures the conversation covers what actually needs to be covered every time, regardless of how rushed the moment is. Facilities that have implemented structured handoff tools consistently report fewer missed details, precisely because the format itself prompts the right questions instead of relying on memory alone. But this system also requires that the nurse and medication aide has uninterrupted medication passes, a system where the concerns that need to be documented is communicated and they can resort back to it once they have completed their medication pass. And that is why a ward clerk is an ideal option for many long-term care settings. Next, let's talk about where verbal-only information becomes formal. Anytime a CNA reports a change, a bruise, a skipped meal, a mood shift, unsteady gait, there should be a fast, low-friction way to get that observation into a written or documented format before it can be forgotten. This doesn't have to mean a lengthy note. It can mean a quick flag system, a shared communication log at the nurse's station, in the electronic health record, or a brief structured entry that takes 30 seconds rather than 5 minutes. The goal isn't more paperwork for its own sake. The goal is making sure that a piece of information that really matters doesn't live only in one person's memory for hours before they have time to write it down, if it gets written down at all. Consider, too, the role that used to belong to ward clerks and other communication support positions. If those roles have been reduced or eliminated, the communication function they served don't disappear. It needs to be redistributed deliberately rather than left to simply pile onto nursing by default. And I would like to say this. I am not aware of an assisted living community that ever even provided a support position. That might mean redesigning front desk coverage, creating a triage protocol for incoming calls, or reconsidering whether that position's elimination or non-existence could actually save money once you account for the downstream costs of communication failures it's leaving behind. A well-functioning ward clerk can also help coordinate communication with pharmacies, missing medications, refill requests, delivery issues, and order clarifications all generate calls and follow-up tasks. When those responsibilities fall entirely on bedside nurses and based on staffing ratios, interruptions increase and clinical focus decreases. When managed appropriately by administrative support staff, nurses regain time for resident assessment, medication administration, and direct care. Protecting medication administration time is another concrete lever. Facilities that have successfully reduced interruption related errors have often done so with visible signals, a designated vest or sash worn during medication passes, a clearly marked do not interrupt zone, or a cultural agreement that non-urgent questions wait until the pass complete. These are inexpensive interventions with an outsized return because they protect the exact window where cognitive load is highest and the cost of a missed detail is greatest. Just imagine how these factors would eliminate the alarming high number of medication errors, hospitalizations, legal litigations, and optimize resident safety, which will also return nurses back to long-term care. Admissions, transfers, and hospital returns deserve their own structured checklist because these transitions are where the most information changes hands at once, often under time pressure, often from a source outside the building. A standardized transfer packet, medications, allergies, recent changes in condition, code status, family contact preferences closes the gap between the hospital told someone and the right person at the facility actually knows. And this is another factor while staffing ratios make a big difference. A nurse having 25 residents, a hospital return or admission with a resident with polypharmacy and all of the ancillary orders that are required will impact the overall outcome and create a negative impact for the resident, the nurse, the facility, and everyone involved. And finally, family communication deserves an honest, proactive framework rather than a reactive one. Many family communication breakdowns happen not because staff don't want to update families, but because there's no clear protocol for when to call and about what. Establishing clear expectations. What triggers a same-day call? What can wait for a scheduled update? Who owns that responsibility on each shift? If a nurse or medication aide has the responsibility of 25 or greater residents and most of their time is consumed with managing medication, redefining these expectations will reduce both the anxiety of families and the burden on staff trying to guess what's expected of them in the moment, especially if they don't have the time. It's also worth naming what leadership's role looks like in all of this, because communication infrastructure doesn't build itself, and it doesn't survive on good intentions alone. Leaders who take this seriously ask different questions in their quality meetings. Instead of only asking, did an incident happen, they ask, where did the information break down and what would have caught it? Instead of treating a missed handoff detail as an individual lapse, they treat it as a data point about a system that needs reinforcement. That shift in framing from individual blame to system design is often the single most important cultural change a facility can make, because it's the only framing that actually produces better systems rather than more fear. There's a quieter benefit to that shift too, one that goes directly to why people choose this work in the first place. When staff aren't afraid that an honest mistake or a missed message will be treated as a personal failure, they stay open. Open enough to keep noticing the small things. Keep sitting with a resident a moment longer. Keep leading with the same compassion that brought them into caregiving. Blame closes people off. It makes them guarded, defensive, quick to protect themselves instead of quick to connect. A system that catches information instead of relying on memory alone isn't just safer for residents. It's what allows empathetic mindsets, compassionate hearts, and caring hands to keep doing what they do best without being worn down by a structure that quietly expects them to be the fail-safe for everything. Budgeting matters here too, and it deserves to be said plainly. If communication infrastructure is worth building, it's worth funding. That might mean protected time for handoffs instead of squeezing them between other duties. It might mean restoring or redesigning administrative support roles that catch information before it becomes the nurse's sole responsibility. It might mean investing in a documentation system that makes real-time entry faster rather than slower. None of these investments will show up as dramatically as a new piece of clinical equipment or a marketing campaign, but their return shows up in fewer falls, fewer medication errors, fewer hospital transfers, and fewer families who feel blindsided or dissatisfied. Outcomes that protect both residents, staff, and the organization's long-term viability. None of these solutions require blaming any individual for the Marthas who fall through the cracks. They require recognizing that communication is infrastructure, exactly like staffing ratios, medication systems, or fall prevention protocols. And infrastructure has to be built, funded, and maintained, not assumed. Now, as we close out, let's have a moment of reflection and go back to Martha Ellison for a moment. Every person involved in her care that day was competent. Every person cared. And still, the information that could have kept her safe, a new blood thinner, a small bruise, a skipped dinner, never came together in one place, in one mind, at the moment it mattered most. That is the truth that we have to sit with across long-term care. Communication is not a soft skill sitting somewhere below clinical competence on a list of priorities. It is the connective tissue that determines whether every other system we've built, staffing, medication safety, fall prevention, care planning actually functions the way it was designed to. A brilliant care plan means nothing if the person carrying it out at 3 in the morning never received the update made at 10 that morning. A skilled nurse cannot act on information she was never given. If there is one message to carry forward from this episode, let it be this: every resident outcome depends on information reaching the right person at the right time in the right way. Communication isn't a soft skill. It is a safety system. And like every safety system in long-term care, it deserves a budget line, a design process, and the same seriousness we give to staffing ratios and medication protocols. The organizations that take this seriously won't eliminate every communication gap. No system is perfect, and long-term care will always carry an element of human unpredictability. But they will close the gaps that are closable. They will stop asking nurses and medication aides to be air traffic controllers without radar. They will give frontline staff confidence that what they report will actually go somewhere. And in doing so, they will give residents like Martha Ellison something they deserve above all else: the certainty that when something changes, someone who can act on it will know. None of this story is about people who didn't care. It's just the opposite. The pharmacy staff who entered that order correctly, the aide who noticed the bruise, the nurses or medication aides who carried the handoff as best they could through a rush shift change. Every one of them showed up that day with empathy, compassion, and caring hands, exactly the qualities this profession asks of them. The tragedy isn't a lack of heart. It's a system that too often makes heart alone carry weight it was never meant to carry by itself. Build the infrastructure, and that same compassion finally has the support it deserves. Free to focus on the person in front of it, rather than on trying to remember everything no one else caught. Thank you for spending time with Empowering Healthcare, where transparency sparks transformation. Until next time, keep asking the hard questions. Keep building the systems that protect the people in our care. And remember, transparency is what sparks transformation. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, and you. And the time is now. Thank you for joining us. We broadcast every Tuesday at 8:30 a.m. Eastern Standard Time. Don't forget to join the conversation, request to be a speaker, and partner in transforming long-term care settings. And don't forget to tune in next week. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelySpoken.com/podcast. That's UNIQUELLEESPOKENC.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.